Recording in progress.
Hi, everyone. We're going to wait about 30 seconds or so for everybody to join us, then we'll begin. Welcome to the AO North America series on finger flaps. We're going to have a wonderful webinar tonight. And I'm your moderator, Sonu Jain from the University of Cincinnati. We have two excellent faculty members here joining us, Steve Haase from the University of Michigan and Sonya Agnew from Loyola University in Chicago. And here are our disclosures. Please also see our upcoming courses that we have at the AO, as well as our upcoming webinars. I'm going to first begin my talk on finger flaps. We'll review the Cutler, the Addisoi, Thenar, Quaba, and Moberg flaps. So with fingertip injuries, the goals are generally to preserve function, preserve length, decrease pain, and to preserve aesthetics. And so on exam, you want to look at the size of the defect. Is there bone exposed? Any complications that you'll find will include cold intolerance, tenderness, and decreased sensibility. I'm not going to go over treatment with secondary intention, as Dr. Haase will review this in depth, but this is an excellent strategy to manage some of these conditions. Skin grafts can be part of your decision tree. Split thickness skin grafts will contract the wound. Full thickness skin grafts tend to have a little better sensibility. You have some donor sites you can choose from, including the hypothenar, wrist, upper arm, and groin areas. And always remember spare parts, because sometimes you may have those available to you in some of these combined injuries involving multiple fingers. So I'm going to first start with our local flaps, which is the V to Y type flaps. Classically, we've been taught about the Cutler and the Addisoi-Kleinert flaps. The Cutler flaps is basically a bilateral V to Y advancement flap raised on the ulnar and radial borders of the fingers, as you can see in the bottom left-hand corner here. The pictures always look much better than we see these flaps in actuality. We rarely do this anymore. I think it's more of a historical exercise. And these are very small flaps and have a high risk of necrosis because of just how small they are. And they're not very satisfying. The volar V to Y Kleinert, Addisoi-Kleinert flap is a little bit better tolerated, a little better able to be done. And it's better for dorsally angulated wounds, which are more favorable to it, as you can see from the cartoon on the right bottom corner. And you don't really get a lot of advance with this flap. You probably get maybe about 5 millimeters. So here you can see with the volar Addisoi-Kleinert flap, you do your V to Y, you free up the septations, and you mobilize the flap distally. And you want to be careful not to devascularize a flap by doing this. So you have to really bluntly dissect those septate that are holding the flap down and allow that to advance distally. And you can see here, you're about getting that 5 millimeters we talked about. This is a case of a gentleman with a crushed injury to the hand, multiple finger injuries, and you can see here that with that, this volar V to Y was done, and afterwards, as it healed, it looked okay. Not terribly exciting, not really that great. You got a little bit of advancement, but nothing to really be too excited about. But in some cases, it's actually reasonable. So, it's good to have in your back pocket. In this case, you have a gentleman with a tumor excision on the back of his thumb, and this was reconstructed with a similar concept of a Vita Y flap, but not in the Cutler or the Adesoi branding. As you can see, that just by advancing that, you can get good coverage. So conceptually, a Vita Y can be used in the fingers or the thumb in certain conditions, and they work well in those. But for the fingertip, not really used as much anymore. So the key points here is that the Cutler, like I mentioned, is limited by flap size and advancement. The Adesoi is used for those volarly favorable wounds, and then you can get about maybe 5 to 7 millimeters. I think typically more 5 in my hands. And then you have to relieve the fibrous tissue from the proximal apex and the sides of the flap, and then also the attachments to the tendon sheath. And you have to trim the nail bed if it's distal to the bony support to avoid any hook nail deformity. So next flap we're going to talk about is a thenar flap. So it's described quite almost like a century ago, and typically used to treat the index and middle fingers. You can divide this in about a couple weeks, and what you have to be careful of in this flap is the age of the patient. You have to worry about creating unnecessary stiffness in those digits. And so you can see here, you base this flap, and you can attach your open wound to it, and then you divide that flap in about 2 weeks, and then you can get some good coverage. So you can see here, usually it's typically distally based, but doesn't have to be, and you can raise that up and do your magic with that. Here's a patient with a burn injury, the palmar surface of his hand. As you can see, this approximately based or radially based flap was created here to get coverage of the radial index finger. And so not a bad option to have for certain situations like this. So the key points for this are it's good for coverage of volarly and favorable fingertip wounds. It gives you glabrous skin, so you're treating like with like. And as I mentioned earlier, you typically raise it distally, but it doesn't have to be that way. And you can typically close the donor site primarily. You don't need a skin graft for that. And you can actually get pretty decent sensory recovery. And as I said, be wary of the finger stiffness. That's one of the things you want to be careful of in patients, over the age of 30. So next flap we're going to talk about is the quad perforator flap. So basically, the radial artery has a prior entry in the palm, branches out into the first dorsal metacarpal artery and the dorsal carpal arch, from which the other dorsal metacarpal arteries arise. This dorsal metacarpal artery anastomoses with the palmar system in the fingers, and this junction gives rise to these perforators from the dorsal communicating branch of the common digital artery. And you can see that right here as the perforators are going into the flap. So this is how you get that system to work for you. So this is a gentleman with a traumatic injury to the radial aspect of his index finger, which also resulted in a nerve injury as well. So this is a true combined injury of soft tissue and nerve defect, which was reconstructed with the process to allograft here. But we have to have coverage for that. Can't put a skin graft over that. Can't put skin substitute. So it's needed a flap to cover this. And so as you can see, I Dopplered out the perforators here, and I had this distally based perforator flap raised and was elevated and used to cover the defect. And you can see 3 months later, we had a pretty good satisfactory result here in terms of cosmesis and function of his hand. So the advantages of this flap is that it provides coverage in areas where you don't have too many other options. And it's important to Doppler not only perforators, but the entire course of the dorsal metacarpal artery as well, just to make sure you have good flow into that flap. So the Moberg flap is described 1964. It's restricted to the thumb. Issues with doing the fingers can lead to necrosis or PIP joint contracture. The dual blood supply of the thumb allows this to be better done in that setting. And you want to maintain the neurovascular bundle within the flap. And you have to elevate it at the level of the flexor sheath. And you can get a good amount of advancement, as we mentioned earlier, with that Adesoy, you're getting about 5 millimeters. This one, you're going to get up to a centimeter and a half, which is pretty good. And sometimes you have to cheat and flex the IP joint of the thumb to get a little more of that flap to advance where you need it to go. But that doesn't necessarily have to happen. So this is a gentleman who had a table saw injury to his left thumb. As you can see, he also lost the index finger to that as well. And the perfusion to this thumb was not viable. We gave it a chance, and it didn't really survive. So we took this to the OR, as you can see, and I also ablated the nail, got rid of that to avoid any nail deformities from going from the site. So I drew out my my flap here and going mid-lateral and making sure I keep myself above the neurovascular structures here. And then I elevate the flap, as you can see here, just along the flexor sheath. As you can see here, the flexor tendon sheath's right there. You can see an injury to that partially from the injury the patient had. But really, you want to elevate the neurovascular bundles in the flap and elevate this just superficial to the flexor sheath and release all the fascial bands lateral on either radial and ulnar sides of this. You can get a good amount of mobility. So as you can see here, I'm able to advance this without really having to flex the IP joint of the thumb. So again, you don't have to do that. And it really approximates nicely. And you can see here at the end of the case, it really is a nice flap to do for this scenario. And then post-op, it maintained itself as viable. The contour is good. And the patient's very happy with it and actually didn't think it was going to look that good, which is always a good thing. So key things to be aware of the Moberg flap is, you can modify it if you need to get a little extra extension. There's an O'Brien modification where you can create a transverse incision proximally, and you basically islandize the flap, and then you can backfill that area with a skin graft. Other descriptions have been using making a VY flap proximally, so you advance it like a V to Y. Proximally to get that area primarily closed without having to use a graft. But these are modifications you can do to get a little bit extra mobility of that flap. And I think, again, be careful of flexing the IP joint of the thumb, to achieve length in older patients, because, it goes back to that earlier point that we talked about with the thenar flap, that you can create unnecessary stiffness, and you don't want to trade one problem for another. So messages to take home from this are essentially the Adesoy and the Cutler flaps have limited advancement, and to be honest, their use has been decreasing, and largely for what Dr. Haase will be talking about later. And the thenar flap, you really can keep this in mind, particularly for the index and middle finger tip coverage, but be wary again. I'm going to keep hitting this point, repeatedly, finger stiffness. And the quadruple perforator flap really should be considered in situations where, you really want to get that coverage just over the MP joint of the finger, and you don't have really other better options there, and it works well. But be sure to really, make sure your perforator's there and you have good vascular supply. And then, keep in mind the Moberg flap for the thumb. It works well. It has great advancement. It's a robust flap that really gives excellent soft tissue coverage that is neurovascularly, providing, reconstruction of the distal tip of the thumb. Thank you. So have our faculty come on screen here, and any pointers, any thoughts about any of these flaps from your experience?
Yeah, it's interesting. I would just make one little comment on the Moberg. I had a mentor when I was in my residency. Dr. John Markley at St. Joe used to say that you can do a Moberg on the index finger as well, because you really lose that dorsal dominance as you go from radial to ulnar. So the thumb does the best with a good dorsal blood supply. He always believed the index finger had just as good dorsal blood supply, but I've never quite trusted that. I did see him do one once and it worked. But we've all seen, or well, some of us, at least I've seen people try to do a Moberg on the middle finger and get sent to me with a bunch of dorsal necrosis, a dead nail bed, and dead dorsal skin. So we do have to be careful with that, and it's definitely the safest in the thumb.
No, excellent point. And one comment about your comment is, I've never had the guts to do that, but I've seen it traumatically where the entire volar vascular system has been compromised from trauma, and miraculously you get collateralization that's able to perfuse that finger. And so so it's not a all or nothing phenomenon. There's a lot of gray there, and and it depends on how much gray hair you want to have before you want to attempt to do that as you go more ulnarly.
Yeah.
Dr. Jain, there's a question from one of the audience members about postoperative protocol for rehabilitation to avoid finger and thumb stiffness after these various flaps.
Yeah, no, good point. I definitely try to, particularly with the DNR flap, I really try to, I think the key point is divide that as soon as you can, closer to the 2-week mark rather than the 3-week mark, because then you can avoid that. But I think what I do is I have mobilized that if they do have some stiffness, I try to, work with our therapist or actually give some exercises to try to help that out. I do try to get mobility where possible on all these flaps, just to get them moving. And so that way, even if I didn't create stiffness, there's no iatrogenic stiffness from, the patient just not wanting to move it, being scared to do so, because that's also another problem. So I get them moving as quickly as possible.
I completely agree with the 2-week division. I think if you have to wait 3 weeks, you might not be doing it in the right patient. Maybe they're a vasculopath or someone who has poor wound healing ability. So I think 2 weeks is a right call there for sure.
Yeah, I would totally agree with all that. I find that the biggest cause of stiffness is patients just worried about moving their fingers. So you really got to do a lot of pre-op teaching. Really got to set the stage that we're going to start moving this on this day. We're going to have a therapist encourage you and work with you if that's helpful, and got to keep a close eye on them in those first few weeks so they don't get set up for any permanent stiffness.
No, excellent points. I mean, these are great flaps. I think you have to just, I think the overall point from these ones are just really just think about all of them as you're seeing these patients. Sometimes you have more than one option with these flaps, and you may have 2 or 3 good flaps to use for that case, but sometimes you don't, and it's just good to be aware of all of them. So excellent. Awesome. Well, we will go ahead and move on. I think we'll go to Dr. Agnew's talk, and so I'll let you go ahead and bring in the second part of flaps part 2.
Okay, so I'm going to talk to you all about homodigital, cross finger, first dorsal metacarpal artery, and reverse radial forearm flaps. And my take-home messages are going to be pretty straightforward. So the homodigital island flap is something that I consider for very small defects with an exposed white structure. That's a Nick Vetterism that I learned from UW. So joint, tendon, something that actually really requires coverage. For the cross finger flap, it's excellent. It's a workhorse flap. It's ideal for exposed flexor tendons of the index, middle ring, and small fingers. And then the FDMA flap is typically used for thumb IP joint coverage. It doesn't have the greatest reach past the IP joint on the palmar side. And the reverse radial forearm flap is best for larger defects in the dorsal MCP joint area or occasionally the thumb. This is a great paper written by Kevin Chung et al. Lots of different options and diagrams. And I am using the pictorial here to sort of outline what each of these flaps that I'm going to discuss can cover. So the size of the circles here that I have are not reflective of the size of the flap that can be covered. It's more the location. So the homodigital antegrade flap is wonderful for small, either radial, ulnar, or proximal palmar defects of the distal phalanx of the digits. And as you can see here, you've got the red circles over the dorsal PIP joints of the digits as well, and that's for the retrograde flap. The maximum size is indicated around 300 millimeters squared. So that's a little bit more than a centimeter and a half by a centimeter and a half. It's a sensate and glabrous flap, but it's contraindicated in patients with peripheral vascular disease, as a lot of these little perforator flaps are. It's a little cartoon that shows kind of the general dissection, the middle axial line here, and the defect with the striped lines is elevated. So the defect of the flap is elevated into the defect on the tip of the digit. And sometimes there's a proximal backfill, as Dr. Jain mentioned, that can be filled with a full thickness skin graft or let to close by secondary intention. Little tips for the antegrade homodigital island flap. You really have to tease the nerve away from the pedicle and leave as much fuzz or fat on the pedicle to avoid stripping it. And you really have to, in order to do that, you have to release both Grayson's and Cleland's ligaments. You want to find the nerve prior to dissection so you can avoid injury to the pedicle, and really don't stretch the pedicle beyond 1.5 millimeters to avoid vascular compromise. This is a article, images from an article that I pulled, and it really makes the flap look quite large. It's really, in my opinion, is not really to be used in such fashion, but in this case, great results for coverage of the flexor tendon in the middle finger here, and similarly in the ring finger, with a wonderful cosmetic appearance. For the retrograde flap, it's a similar concept. It's based on the ulnar radial digital neurovascular bundle. But the key here is avoiding compromise of the flap by avoiding dissection around the communicating arteries, depending on where you're transposing the flap to. So typically this is used for dorsal defects, but it can be used for a palmar defect, as it's described here in this picture. This is a patient, courtesy of Dr. Friedrich, exposed PIP joint. And as you can see, the defect is over the PIP joint of that index finger there. It's been covered very, very nicely. And the communicating branch is that palmar PIP joint branch. So the donor sites are typically either closed with a full thickness skin graft, or sometimes let to close by secondary intention to avoid any kinking or excessive tension across the pedicle. We're going to move along to the cross finger flap, which I mentioned is a kind of a workhorse flap. Many hand surgeons have either seen this or used this. It's excellent for the defects shown on the right here. So can be used for palmar defects. And the reason why it's not used for the PIP joint of the small finger and the volar surface of the middle finger is because there just isn't a really great corresponding donor site at those locations. It does depend on the length of the patient's fingers. But basically, I use it most for exposed flexor tendon on the palmar side of the digits. Unfortunately, it does provide non-glabrous skin, so I don't think it's great for distal phalanx coverage. And the big downside is it's 2 stages and requires a period of immobilization, which is kind of a no-no, as we all understand. It's described as fitting a 1-to-1 ratio. So we can basically, the flap you elevate should be the size of the defect, but in my opinion, it should be harvested a little bit bigger. But the overall size recommendations for the flap are between 2 and 3 centimeter defects. So nothing really bigger than that. If it's longer than that, that's not likely to provide full proximal to distal coverage. And again, you have to be cautious in diabetics and elderly patients. It does unfortunately have a conspicuous donor site, which is something to consider based on the defect that you're trying to cover. Is it worth the donor site? So some pearls about elevating and insetting a cross finger flap. So you have to release Cleland's ligament to basically unfurl the flap and let it drop into the defect. And it's this distance between the donor site and the recipient site that requires that you elevate a flap that's larger than the defect, so it can actually reach across, because you lose some length there. You have to full thickness skin graft the donor site, and of course leave peritoneum so the graft can survive, to leave that nice veil on the extensor tendons. And again, dividing on the side closer to 2 weeks to prevent finger stiffness. And the reason why they get stiff is obviously because there's a little bit of a length discrepancy between the 2 digits typically. And so you have to flex one in order to allow the flap to inset. This is a patient who has exposed ulnar digital nerve and flexor tendon with no sheath. And I thought was a great indication for cross finger flap. He's young, non-smoker. This is him at after elevation. As you can see, I kind of shorted the flap, so it doesn't provide full radial to ulnar coverage. The full thickness skin graft is inset very tight on the dorsum of the ring finger so that it improves the take. This is him at 2-week division. And as you can see, the flap looks nice and healthy, a little bit of maceration between the digits. Interestingly enough, you can see there's a little bit of flexion contracture on the donor finger, and that donor site is quite pink, but with time it can fade. It depends on the patient's pigment. We're going to move next to the first dorsal metacarpal artery flap, which I think is a little bit more of a challenging flap, in my opinion. It can be killed quite easily. It's really typically best used for dorsal IP joint thumb defects. It has a more natural lie, but it can be used for palmar defects of the thumb, just really not reliably past the IP joint. It is non-glabrous, but the benefit is that it's a single stage reconstruction. And the size of the defect it can cover is the size of the width of the index finger, proximal phalanx. So that's how you know how much you can cover. Does again have a conspicuous donor site. It was first described by Guy Fouché and Jean-Bernard Braun in 1979. And these pictures don't really emphasize that you really cannot skeletonize the pedicle. I can't emphasize that more. This cartoon shows a little fat on the pedicle, and that's really, really critical to improve the survival of the flap itself. They can be both proximal and distal based, but it doesn't, again, reliably resurface the entire surface of the volar side of the pulp. So in my opinion, it's best for IP joint dorsal or radial defects like this patient, whose photos were shared with me courtesy of my colleague at Northwestern in Chicago, Jason Coe. You can see this is a cancer that's on the ulnar aspect of the patient's right thumb with a little bit of involvement of the nail. This is the tumor after it's excised with some exposed distal phalanx and nail matrix. A great indication for this flap. And as you can see here, Dr. Coe has a lot more confidence than I do. He chooses to tunnel the flap, which I'm always afraid to do because I'm worried about congestion of the venous supply, but it looks beautiful here inset. There's a little burrow triangle taken out of the over the MCP joint to improve the appearance of the cosmetic defect of the donor site. As you can see, wonderful cosmetic results, an excellent range of motion. As you can see, though, I want to point out that it doesn't really quite reach to the tip of the thumb. So great flap, but don't try to use it to resurface the entire native length of the thumb. This is one warning that I have for you about the non-glabrous nature of the dorsum of the index finger. There's a patient who was very unhappy with both the hair growth on the flap and the fact that it wasn't glabrous. So he really had trouble gripping and grasping objects. He felt like it was always slipping. And he even asked me to take it off and put a skin graft on it so it would be more scarred. So leaving you with that message, moving on to the reverse radial forearm flap, which is really a workhorse flap for my trauma patients. It can resurface the entirety of the dorsal hand, which is not the focus of this talk, but it can also be used in isolation of the thumb defects. It can be taken as a fasciocutaneous or fascia-only flap. Very cautious in patients with peripheral vascular disease. And it can cover all the way up past the MCP joints, but it does require a little bit of a delicate dissection. I typically use a Doppler Allen's test. So I occlude the vessel and I ensure that I've truly occluded the vessel by listening between my two fingers, ensuring that I've occluded the vessel, listening to both the thumb pulp and the palmar arch as well as the small finger to confirm that I can harvest the radial artery without sacrificing flow to the hand. My personal preference in obese patients is to use fascia only and split the skin graft because it's a little bit puffy in those patients. And I generally don't tunnel these flaps. Again, I think they're more reliable when you divide the skin bridge. There's a patient I used it for recently who had a degloving injury of the dorsum of his hand and lost a significant amount of the articular surface of all of his index through small fingers, MCP joints. And again, I used for the purposes of lower profile, uses a fascia-only flap. It reached just past the MCP joints, which I pinned in flexion to sort of create that domain that would have otherwise been lost. And as you can see, I've skin grafted the pedicle as well. Sort of an unsightly scar, but really over time can fade. And this is a patient that I used with skin. As you can see, it looks like a little bit of a muffin on the dorsum of her hand, but for other reasons, ease of raising again for her wrist issue, I chose to use skin rather than fascia with skin graft. So my take-home messages are sort of simple and straightforward. I really only use a homodigital island flap for small tip defects. It's quite a delicate dissection and can leave a unsightly donor scar. Cross-finger flaps are for palmar, proximal, middle, and distal phalanges. It's reliable, straightforward, but unfortunately takes 2 stages. First dorsal metacarpal artery flap is excellent for the IP joint and P1 thumb coverage, but it's non-glabrous. It does require quite a delicate dissection. And the radial forearm flap is excellent, reverse radial forearm flap, for larger defects of the thumb and hand. And that is all I have for you. Stop share.
Awesome talk. That was great. Talking about the FDMA, I totally agree with you. I get nervous tunneling it, and what I have done is I almost raise it like a small flag flap where I leave a little dorsal strip of skin. It does 2 things for me. It, number one, doesn't tunnel it, so I don't have to worry about the skin bridge congesting it. And number 2, it also provides a little subdermal plexus of venous drainage. So it helps me to sort of feel better that I'm not going to get as much congestion from it. So it's a little more work because you have to throw in more sutures to kind of suture the entire length of that. But it works well, and I've had great results from it. Nothing wrong with tunneling it. Sometimes you have a great distance. You have a good length of flap. Provides a little subdermal plexus of venous drainage. If you do it in a younger patient and the skin is a little more taut, doesn't have that give, I do this and I sleep better at night.
I totally agree. I totally agree. I love the FDMA flap. I find it's always trickiest to divide the little branches that come off the arterial pedicle right near the MCP joint, right near the sagittal bands. You always think that you've cut the pedicle, but you've just cut the branch that goes off deep there. Because there you have to dive deep and almost have to cut a little bit of the sagittal bands to raise that, I find. But I always take it with a skin strip over the pedicle as well, like a 1 centimeter strip of skin. I'll bevel that out and take about 2 centimeters of the fascia and fat just to make sure, because I'm paranoid about that circulation. And then I split the whole distance, not tunneling it, and just raising the flap so it looks like a bit of a badminton racket or something is the way I've done that. And I find it reaches pretty distal. I would agree that getting to the tip is hard, but I've taken it a little bit extended, taken a little bit more of the index finger skin, even taking the skin over the PIP joint when I really needed it. And I don't find that the patients get too bothered by the donor site being a little bit longer. Otherwise, yeah, one of my favorite flaps. And don't forget that FDMA, I think in most of my patients, it's been a sensate flap because I keep my eyes out for little branches of that superficial radial nerve and try to harvest them with a pedicle. And in most of the patients I've done, they've had pretty good sensation there that they eventually figure out it's the thumb and not the back of their index finger.
No, I agree. It does both, and it's a great workhorse flap. I think it's probably of all the flaps we've discussed so far, it's probably the one I probably do the most. So, yeah. And I mean, and I do want to emphasize, I think don't ever forget that radial forearm, especially if you are not in a situation where you can do microvascular surgery for somebody who needs something. That radial forearm can really be a bailout for a lot of bad hand defects and finger defects.
Yeah, excellent point. I think also with the FDMA, that we put a premium on thumb coverage. And so I think that's an excellent point of sacrificing a little bit of an ugly donor site on the index finger so you can have stable coverage of the thumb is something that we all sort of can relate to. So great point there.
Excellent. Well, we will go to Steve for your talk. Tell us how we can do things the other way.
All right. Let me get this into presentation mode here. Is that doing it? I think that'll do it. All right. So I wanted to share a little bit about, I guess, some non-flap finger flaps, some things that I do and had some success with that don't require dissecting out a flap and creating a donor site. But then I will put in a little plug for a good workhorse bailout option when you don't have a local or a regional pedicle flap available. And sometimes we have to go to a more distant flap. So I threw in one more distant flap for an example of that. I think that my goals here are to help you recognize what fingertip injuries might be appropriate for healing by secondary intent, to look at the indications and limitations of composite grafting in fingertip injuries, and then discuss the use of distant flaps for select cases. We've already talked a little bit about this. When I think about goals of reconstruction, obviously we want to preserve length. We're looking for stable and durable coverage that is sensate. And then I think about the timeliness of our reconstruction. How long is it going to take to get through the process? How many operations is it going to require? How long is it going to take to heal? And then, of course, we want things to look aesthetic when possible. We are all familiar with the reconstructive ladder. I won't belabor this, but we do think about primary closure in some situations, but we don't like it when it requires too much shortening. And then secondary intent healing often takes several weeks, so that gets into the timeliness issue. We've talked a little bit about skin grafts and flaps and how flaps can often provide better sensation if they're sensate. Composite grafting, I was always taught, is only for very, very young kids and fraught with difficulties. And we've all had cases where it doesn't work out, but I'm going to share some cases where it's worked out at least to some degree. And even if you get partial take on these, it can be a big boon for the patient. So I also put in a slide here on my general philosophy. I think we've talked about this a little bit in our discussion already. I think that a lot of this is focused on shared decision making. I like to give patients a choice. There's often one or two things that might work out for these fingertip injuries or larger defects. And I like to be able to give a patient a choice if I can, telling them pros and cons. Again, I emphasize sensation if possible, and keeping things as simple as possible, I think is also one of my goals. So here is a patient that presented to me with a table saw injury to the thumb. As you can see, this, at least in my hands, this is not replantable. Most of the nail bed and distal pulp skin were avulsed. Tissue was lost as well as avulsed, and this presented to our ED. And this was one of the first cases where I decided to pursue for this larger defect with bone exposed and everything, healing by secondary intent, and see if it could accomplish what I had been hearing about. And I've been hearing about it a little bit because one of our faculty brought up this article during a conference one day, and it really struck me as this is a very old idea that I just really didn't learn in my fellowship. And so I started using it religiously many years ago, and it really has not ever let me down. This is just one of the old papers that talked about this from 1993, about using basically whether you're using, there's different brands out there, but basically a semi-permeable membrane dressing, one of these self-adhesive thin plastic dressings that can let oxygen in and let the wound breathe a tiny bit, but it keeps bacteria out, it keeps the wound from desiccating. And with all that covered up, it's a lot less painful, especially once you get past the first few days or past the first dressing change. It's not too painful. And one of the arguments they made in this older study, at least, is that patients got back to work pretty quickly, even when it was still healing, because it was covered and a little bit protected and not painful. I don't think that works for all lines of work, but it's a lot of my patients do get back to their ADLs and work without worrying too much about this kind of a dressing. But so the protocol is to trim back any exposed bone so it's not too prominent. I tell my trainees just make sure it's not sticking out more than the soft tissue, so it's at least level with the soft tissue. And then apply this film without any tension, sealing it to the dry, intact skin around the wound. And then change it weekly, avoiding the temptation to change it more often, because we really want this to sit still, protected, and start healing for a full week at a time, just to kind of let the to not disturb the process. What that looks like, what that leads to, is something like this after 1 week: a big gelatinous, brownish, smelly blob of stuff on the tip of the thumb, which you have to fight the urge not to debride, not to wash away, because all that is like a healing matrix of goo that is essentially the building blocks of the network of tissue that's eventually going to reepithelialize. So you have to just keep the skin as dry as possible. You can see you always get some maceration, but kind of clean the skin around the wound, get it dry, and put on a new tegaderm without disturbing that clot. And this is the progression over time. This was at 2 weeks. You can see that it's still a little gooey, a little stinky. This is at 4 weeks, where we've actually got some pretty impressive epithelialization over that clot already. We're already starting to see some nail growth, or a little bit of nail peeking out from nail matrix that I wasn't even sure was there when we started. And I will say that sometimes this hypergranulation tissue is really tempting to apply a little silver nitrate, and some of our folks in the office will do that when they see this. I don't know that you necessarily have to if you can get a good seal with a tegaderm, but we'll sometimes treat this with a little silver nitrate to discourage that hypergranulation. This was him at 5 weeks then, as the fingertip is looking more and more like a fingertip. And then at 6 weeks, nearly completely epithelialized with even more nail growth. So this really impressed upon me what you can get with just a little bit of time and a once a week simple dressing change. This is, I think you can see here that we have grown a lot of new substantial tissue that then reepithelialized and looks pretty much like the thumb used to, which always amazes me what you can do with this technique. After the first week or two, most of the patients are just asking for some dressings to take home, and they do it themselves once a week, and don't have to come to the office every week for this dressing change once they get used to it and comfortable with it. So I do this a lot now. I just included this one case to kind of show what I think is the power of this technique. And I'll move on now to talk a little bit about composite grafting. So this is, I'm presenting 2 cases here. Both are fairly similar. This is a 13-year-old student who was jumping up to swat at the horse, the steel plate with a horse painted on it, which is the mascot at his school. It's, you know, kids, especially young boys, love to show off by jumping and see how high they can jump. And he caught his finger on the horse ears, which took me a while to sort this out because he kept talking about the horse in the ER, and I didn't know what he was talking about. Not a real horse, but a sharp edge of a horse, a plaque in the hallway at school, and sheared off probably, I would say, 75% of his nail matrix and quite a bit of skin. We have exposed tendon. We have a kind of composite graft here that encompasses nail matrix and skin and a tiny bit of bone. In his x-rays, you can see he also has a Salter-Harris 1 fracture of the growth plate and a little deviation there. So after considering options here, I decided to try composite grafting, even though I thought this child was a little bit old for that. I thought that it might be at least a bridge to another form of reconstruction after seeing how it went. And if it didn't take, then we could talk about other local flaps. I had, in preparation for this talk, I was looking for some review articles on this, and this one was published a while back, but really confirms my experience. So I wanted to share it with you, that most of these have just a partial take. It's rare to get a complete success. In this study, 39 patients from the ages of 1 to 18 had some sort of grafting for pediatric fingertip injury, and about 60% had partial take, and about 1/3 had complete failure. Very few have a complete success. But what is interesting, and this is kind of a small sample, but in their statistics, age did not significantly associate with success. There was a small trend toward younger patients doing better, but it did not reach statistical significance in this rather small sample. So this is what we did. We put a little pin across the fracture and reattached this tissue meticulously, as you can see in the upper right. Here's the dorsal view where the nail bed repair, and a shot of the temporary K-wire that we placed in there. Hoping for the best, and this was the result. So this is him at 3 months. Obviously, the pin is long since out, and he's been doing dressing changes and awaiting healing. We ended up with an eschar that was significantly smaller than the graft we put on. I think you can see the margins of the graft are out here somewhere. So we ended up salvaging a lot of that tissue, and did a minor debridement to remove the eschar, and then allowed it to, again, to heal by secondary intent, with this being the final result. So we ended up with a fairly reasonable fingertip, with a reasonable nail growth and good function, and one shot here of the before and after. I think you can see that not a complete success, but a lot of that fingertip was able to survive, and a complex graft that contained nail bed, but very little bone. I'll share this story next, a similar one. This is an 11-year-old that caught their finger on the sharp edge at the upper part of their locker at school. This arrived at my emergency department after they had called several hospitals who would not take the transfer because they would not consider replantation. And then U of M accepted it without asking me about it, but it came to our ER, and the mom, who is a medical professional, a dentist, I think, was insisting that we try to replant this and not just do a revision amputation. This was the amputation that this child suffered with a loss of the distal pulp as well as all of the bone distal to the physis. You can see in the x-rays that we're missing everything, only having the epiphysis remaining. So I thought about this, and I knew that one of the sort of principles I think of composite grafting is a small graft should do better. But if you have a bigger graft, it's about having a large touchdown area, a large area of contact, I think, for revascularization to occur. And this doesn't have a big touchdown area, a lot smaller than that last case I shared. So I kind of stretched my mind and decided I would do something a little different and see if it would give us an edge. And you can decide for yourself if it gave us the edge I was looking for. But I put this on and pinned the fracture, and then decided that to improve the touchdown area, I would supplement this with a cross finger flap to apply some vascularized tissue from the middle finger to the graft to give it more contact area to healthy tissue, and would take a little skin from the graft and the composite graft and use that to cover the donor site like a mini cross finger flap. So you can see I'm elevating about half of the tissue from the composite graft, and this is the outline of the tissue I designed from the middle finger to inset on the composite graft. So we attach these two fingers together for I think 3 weeks, and this is where the stress begins, because we wrap them all up and check them a week later, and actually 2 weeks later, and this is what it looks like. And I'm thinking to myself that, well, that didn't work at all. But you have to be patient, and some of this is just clot, and we waited, and this was him a week later. It's actually starting to look a little bit better with, this actually looks necrotic, but I knew we would not save the whole graft here. At 3 weeks, we divided it. Actually, at 4 weeks, we divided it, looks like. And I think you can see here that our graft from the middle finger to the composite graft survived. So it somehow got some blood supply. It healed to the graft, which it tells me that the graft underneath there is probably healthy as well. The little piece of essentially skin graft to the dorsum of the ring middle finger did well also. We dragged our fingers for a while then, we dragged our feet for a while then, and waited to see what would heal. Ultimately, he still was unable to resolve this last bit of necrosis. So we did one final debridement and closure with the remaining tissue. And this was the final result. This is actually 9 months later. He came in for a long-term checkup, and you can see he's got nail growth without any hook nail deformity, because a lot of the bone survived as well. And we did lose the distal tuft, but a lot of that bone survived. And here's the sort of before and after. So I think that you can appreciate we saved some nail matrix, not a lot, but some, and a lot of and some bony support for the nail survived from our composite graft, which they were very happy about. And we didn't end up with much of a donor defect, although there's an obvious little scar there. This last one I'll go through, I guess. We'll try to save a little time for questions here, of course. But this is very similar to one of the cases that Sonya showed. It's tough when you have your hand out the window and then your car rolls over. It tends to be bad for the dorsum of the hand. And this went down into the fingers. We had joint and tendon injuries here for sure. And I won't focus on all of that at this conference, but you can see it was pretty severely damaged. And even when you get it cleaned up, there's not a lot of local flaps for this. Radial forearm flap could be considered. In this case, I decided to do something a little different. I wanted some fairly thin tissue, and this is a very lean guy. So we went to the torso. Many of us are familiar with the groin flap, but there are many other flaps that can be raised from the abdomen. And for this case, I chose paraumbilical perforator flap. As you can see from the graphic on the left of the screen, the paraumbilical perforators kind of have multiple anastomoses with other systems, so you can raise a flap in almost any direction you want, but kind of raising one out laterally to capture all the vascular connections between these systems tends to work well. So for this young man, we designed this flap. The perforators arise here and tend to perfuse out pretty nicely through that vascular network. When you as you can see here, we got some of the wounds closed, but we still had a large wound with exposed bone and tendon and joint. When you go to raise this flap, in a young, healthy individual, of course, the wound immediately springs open, and you're wondering if you can ever get that closed. But you can usually close the donor site if it's not too wide. And that left us with this flap to apply to the dorsum of the hand, which I thought was quite thin coverage. And that ended up doing well. We divided him at 3 weeks, went on to sort of do the release of that syndactyly at 3 months. Then he had one further debulking procedure, because even though I thought the flap was thin enough, he didn't like the puffiness of it. And this was his final result at 1.5 years after injury. Unfortunately, he never got great IP joint flexion. Some of those joints sort of auto-fused after all the trauma, but he had a thin but stable coverage. Of course, he did have to trim the hair on it regularly, as you can see. One of the downsides that Sonya also pointed out when you don't use skin that's an exact match in terms of hair-bearing qualities. So again, there's the before and after with his reconstruction with paraumbilical perforator flap. So I guess these would be my take-home messages. I think we all know secondary intention works great, even if there's bone exposed, but it is a little bit slow and may not be right for every patient. Composite grafts can be helpful, even if the take is incomplete. And I would argue that age is not the biggest factor, although I wouldn't put a large graft on in an adult. I would definitely consider it in the pediatric population, even in teenagers. And when you need to cover a lot, consider something that's very reliable, and distant flaps may be an option if other workhorses like the radial forearm flap are not available or not desirable. Thanks for your attention.
That was excellent. What a win with that pop flap. And I was actually going to comment on the fact that you chose an area that was less hairy and so different than a groin flap. But unfortunately, I guess I was a shaved patient. But yeah. A huge win. I mean, the cosmetic appearance of those can be very unsatisfying sometimes when they're larger, and it was a really nice looking thin flap. We have some questions from the audience about composite grafting. What composite do you apply for grafting on kids? And it's maybe more towards like, what is a composite graft exactly, I think, is where that question is coming from. And then the role of GRF composite graft in fingertip injuries.
Oh, well, I would say when it comes to composite grafting, I think, as you can see from the cases I've showed, I'm not shy about replacing a graft like that, even if it contains bone. Sometimes if it's a small amount of bone, I will remove the bone or even thin the flap a little bit. Again, if it's a smaller amount of tissue, then I think the chance of success is higher. So I will sometimes debulk the flap if that is reasonable to do in terms of trying to get it to get a better take. And I confess, I don't know what the acronym GRF stands for. Is that something I should know?
I'm glad you had the same question, because I wasn't certain either. Maybe Dr. Ong can type in the comments. But I will ask you sort of to expound a little bit more on, do you put the composite graft on the emergency room? Is it something you take to the operating room? And how much do you defat or debulk? What's your thought process there?
So I would say for those two cases, I did them in the operating room. For smaller things, that doesn't always happen. If it's a tiny fingertip injury in a very young child, and the residents can get it, a reasonable sedation done in the ER, where there's no bony fixation required, where there's no other flaps that need to be raised, then I think I would still sometimes supervise the residents doing that in the emergency room. But that does require a little bit of sedation, especially for the younger kids. when I know that I'm going to need to put in K-wires and things like that, I prefer to go to the full sterility of the OR. And in terms of debulking, well, I'm probably not very consistent. I think that in that first case, I did remove the little chip of bone that was there and thinned out some of the subQ fat, but I didn't want to take away too much of it. I definitely wanted to get good coverage for the flexor tendon, for example. For that second case, I don't recall debulking it at all because I really needed the whole flap to cover the bone, and I didn't want to remove any bone. So that's how I've dealt with it on those cases. I probably have not been totally consistent internally, but I see there's a question about use of the vac in the hand. Interesting idea. And certainly in our, historically, at least when I did more burn care, I've used it for large burn injuries. I've used it as a bolster dressing for large skin grafts. I think you have to be very cautious. I was involved, thankfully, I was involved in a very unfortunate case, which was sort of a sentinel vet in our hospital where a vac had, where multiple attempts at getting a better vac seal on an extremity led to an ischemic hand problem. So you have to be very careful. My policy is always to leave out the distal fingertips, even if they're not completely, covered, even if there's open wounds, leaving some sort of distal fingertips open so you can always keep an eye on distal perfusion.
Yeah, I've seen some wonderful, the use of surgical gloves with the fingertips cut off. The glove is placed, and then just like we put a small hole in the glove itself, and then the sponge over that, which really holds suction very nicely. That's probably a talk on its own to how to put it on and how to get it to seal. And then there's a question about just covering the fingertip with Xeroform and changing it every week. What are your thoughts on that?
Well, my thought would be that even after a few days, that Xeroform gets really, really stuck on there. You're going to have to soak it forever to get it off. And I don't think it does as good a job of retaining the moisture and keeping the wound from drying out, because Xeroform, even if you added a bunch of Vaseline or bacitracin to it or something, it's often going to get stuck and not do as good a job of preventing desiccation and holding in that moisture that you want. Still, I do like, Don Lalonde's rule, keep it greasy. That works really well. So if you got someone who just doesn't tolerate the tegaderm, or if someone wants to try something different, I tell them, just get a jar of Vaseline and keep it greasy. Just put on a layer of Vaseline and some sort of Telfa or Xeroform to kind of retain the moisture. And you may have to change it more often than once a week in that case. But keeping it moisturized will let those things heal as well. I think the tegaderm is just tidier, easier, and has to be changed less often, which I like.
Yeah, I think also from like a cost perspective, sometimes maybe, it's hard sometimes for people to find that. So another option, like you mentioned, a la Don Lalonde, is to use the bacitracin and use Coban and basically use that as your wound chamber. But again, I think you're gonna have to change that a little more often than the offsite or tegaderm. So I completely agree. And let's see, I think we have about a minute left here. And so I think we answered all the questions.
One more question about when you let the fingertip coverage to wash the hand in water. I'm a big, huge fan of water, so long as it's clean water. It doesn't have to be sterile saline, and soap and water particularly, to kind of emulsify the bits of blood and dead fat. So I'm a huge fan of soap and water immediately. In a dirty wound, immediately. In a wound that was created surgically or is somewhat cleaner, then I usually tell them to wait 3 days to have it touch water.
Mm-hmm. Yeah, basically, as soon as the post-op bandage comes off, whether that's a 3-day light dressing or whether it's a splint that you take off in a week, I would let people start washing right away. For open wounds, if I'm doing the tegaderm thing, the idea there is to clean the skin around it gently and carefully, but to not disturb that clot. But otherwise, they can wash the rest of the hand and wash around it. That's sometimes daily hand washing with the tegaderm in place makes the tegaderm get loose and stuff like that. So lately, my MA showed me how she's been telling patients to actually wrap a little Band-Aid around the base of the tegaderm just to secure it a little bit more. And that seems to help. So there's lots of little tips and tricks that the patients and my MAs teach me.
Just avoid well water.
Yeah.
So beware of that. On that note, I think we are just about concluded with the webinar. So I want to thank you, the audience, for joining us. And I want to thank our wonderful faculty for their great talks and really, sharing their knowledge on complex injuries of the hand and fingers. So thank you all. And we'll go ahead and conclude. And, for the audience, please keep in mind our upcoming webinars and AO courses, as we mentioned earlier at the beginning.
Thanks all.
Yep. Thanks, everybody. Great. Everything went very smoothly. Thanks to all of our support.
Recording stopped.
Well, guys, that was fun.
Great. Well, thank you all. Appreciate it. And thanks, Chris and April. And, everything went well. So have a good night, everyone.
Yep. Good night, everybody.
Take care.
you.